everybody. I'm Mary Elliott. I am a PA in rheumatology with New Haven Rheumatology in the New Haven area of Connecticut. I've been practicing for 3 years, and I'm happy to be here with Alanna, who will introduce herself.
Hi, everyone. My name's Alanna. So I am the Assistant Dean of Graduate Nursing. I run the FNP program at the University of Mount St. Vincent in New York. And I practiced for 22 years at New York Presbyterian Weill Cornell. Half of that was in my pulmonary practice. And then now I'm doing continue 1 day a week at Stanford in Connecticut.
Okay, let's go to the next slide. So we're going actually go back to the first slide. So we're going to be talking about 2 cases today where we are recognizing and managing not only rheumatoid arthritis-associated ILD, but we'll also be talking about a scleroderma case as well. So beginning with rheumatology, or beginning with rheumatoid arthritis, I should say, what's very interesting is that we find that there's clinically significant ILD in 5 to 10% of rheumatoid arthritis patients. As patients live longer with rheumatoid arthritis, as they experience more years, we find a higher frequency or prevalence of ILD. For instance, patients with rheumatoid arthritis over 4.4 years, their incidence of RA-ILD is 3.7%, and that goes up to 6.3% at 15 years and 6.8% at 30 years of disease. There's subclinical ILD in 20 to 40% of rheumatoid arthritis patients, where you can see these radiographic abnormalities, but not necessarily clinical symptoms. And this is progressive in as many as 29%. So we're going to be looking at a particular case of a patient with RA-associated ILD. Let's go to the next slide. So this patient, we'll call him LBJ. I keep thinking of Lyndon Baines Johnson, our 36th president, but he is a 67-year-old male. He comes in, to primary care or maybe to rheumatology with the presenting concern for increasing fatigue, shortness of breath, with mild exertion over 6 months. He was diagnosed with seropositive rheumatoid arthritis 4 years ago, and he has very high titers. His rheumatoid factor is greater than 300. His anti-CCP antibody is greater than 60. He has been on methotrexate. Adalimumab was added 2 years ago as he had ongoing disease activity. And so the question here is, what features in this history suggest a higher risk for ILD? And if anybody wants to chime in, feel free to chime in. But I would say that there's a number of factors here. Number one, he's seropositive. He has high antibody titers. He has combined rheumatoid factor and CCP positivity. He's male. He has older, and his disease started when he was older. He has 4 years of disease duration. Also, sometimes the presence we don't know, the presence of rheumatoid nodules can be another factor, but there is definitely a consistent association between seropositivity and ILD across both clinical and subclinical disease. All right.
Yeah. And I would just add, Mary, that he looks like he's symptomatic also, right? He's having respiratory symptoms, shortness of breath, mild exertion, right? So, I'm always looking at the pulmonary step. So,
Yep. And then getting to that pulmonary step. So I take a listen, and sure enough, he has inspiratory crackles on auscultation. That's going to be the next slide. Sorry. Next slide. Next slide. There we go. Wonderful. Getting to Alana's point, we can hear those crackles. It sounds like Velcro when he's breathing in. He has his SpO2 is normal when he's at rest, but he desats when he's walking. We get a chest X-ray. It shows vague, interstitial markings. What does that mean? We're gonna talk about that. And then what I'm going to do is I'm gonna send them to pulmonology over to Alanna. So I'm gonna have you take it from here, Alanna.
All right. Thanks, Mary.
Yeah.
So just to kind of run down the inspiratory crackles is odd, right? And so often when you're hearing that, we say Velcro or crushed. I like to say dry, crushed leaves in the fall. That's a sign of rails, right? There's something, there's fibrotic tissue there. So it's not, aerating the way it should and diffusing oxygen the way it normally should, right? Um, the oxygen being normal at rest is good, although if he's desaturating when he's walking, it also means he's desaturating when he's, cooking in the kitchen or doing a shower or anything like that, anything with any strenuous. So you certainly want to consider, how much is he desaturating and does he qualify for ambulatory oxygen? And potentially oxygen as well when he's sleeping, because that's often people who are kind of on the border like this also need to be tested while during sleep. The interstitial markings on chest X-ray are really nondescript. Sometimes it just looks like more predominant airways, right? Whether it looks like like some bronchiectasis, it's really nondescript, and so really you're going to want to get a CAT scan of the chest. And if you're kind of thinking, well, maybe does this person have, interstitial lung disease at all, then you're going to want to go for that high resolution CAT scan rather than having them get two different CAT scans. So if you're able to qualify that, save the time, right? Get the high resolution if you can. And then, like Mary was saying, the initial tests with the spirometry there, if you remember, anything greater than 80 is considered normal. So that forced vital capacity of 65% is reduced, and that DLCO of 41% is also quite reduced. And so, you're not seeing a normal pattern there. And it's really restrictive, right, in nature with the forced vital capacity being low, but also not a normal diffusion. And then it looks like they did get a high resolution CT. They just threw that in there. And it looks like what it says is it's a basal predominant reticulations with the honeycombing consistent with a UIP pattern. So this is really concerning for fibrosis here.
And, that was one of my questions when I was looking at this case. Does a UIP pattern always mean fibrosis or generally mean fibrosis?
Yeah, it's a tricky question. You
Yeah.
you and I have talked about this a lot,
I
but
know.
in general, I would say if when you see UIP, probable UIP, you're starting to think of fibrosis. That is really what you're thinking about. And then, when they're saying the classic stuff like honeycombing or basal predominant, those are kind of the catchphrases when you start to think, okay, does this person have fibrosis? And likely the answer is yes, but it's not a simple answer. Often you have to see it. You're seeing the whole film, and not just taking the read, because you're also looking at the film and where those things are happening. But typically, yes, yeah, typically a UIP pattern means that there's some fibrosis, but not all UIP patterns are idiopathic pulmonary fibrosis, right? So it may be other types of fibrosis.
So if we see this, we order the HRCT and we see this, we're suspecting UIP. Would you see UIP? We're suspecting fibrosis. And it's interesting. I did look at the American College of Rheumatology guidelines and chest guidelines for what to recommend next. What do we do now for suspected RA-ILD? And just as far as what they say, the first line would be mycophenolate, azathioprine, or rituximab, which is kind of interesting. We're going to talk about, what's actually done in this particular case. But for people with RA-ILD, the panel was not able to come to a consensus to recommend nintedanib as a first-line ILD treatment option, which is interesting, and so I'll have questions about that down the line. But next slide, please. So, confirming diagnosis and multidisciplinary evaluation. So now we've got pulmonology and rheumatology. Alana and I are working together here to figure out what to do. And we've got we've referred to pulmonology. We have a confirmed diagnosis. We've got RA-ILD with this usual interstitial pneumonia phenotype. This patient has been on methotrexate for 4 years. He started adalimumab 2 years ago. And again, he's got these high risk profile, high titer RF, CCP. He's male. He's had disease onset at an older age. What's interesting too, when I think about this, is that more women are diagnosed with RA, but it's actually the men who tend to get the ILD with RA. And there's 2 questions. We've talked a little bit about the baseline and the follow-up assessments with pulmonology, but one of the questions that we get often is, should methotrexate be continued in these patients with ILD? And for years, in rheumatology, we've shied away from the methotrexate. It was thought that maybe that could, A, precipitate ILD or maybe make it worse. But there's now evidence out there's a recent systematic review that found that methotrexate does not cause ILD and it does not make it worse. Um, Methotrexate can cause pneumonitis, which will typically be more of an acute onset, usually maybe 2 to 3 weeks after, a shorter time after starting methotrexate. But it has not been shown to cause ILD or worsen it. So now we're always asking ourselves, well, okay, he's got ILD. Should we stop the methotrexate? Should we continue it? Is it safe to do it? But so far, that data has been reassuring. So, next slide, please. Um, let's see. So, treatment decision and evidence-based management. We've as in rheumatology, we've worked with pulmonology to coordinate care, and the patient is started on nintedanib. Sorry, I'm butchering the pronunciation.
Nope, you did great. Tentative, yep.
Somehow I have trouble pronouncing the word. It could be an easier word, but, it could have made
Yeah,
it
they all could be, right?
but, so, you know, I don't have as much familiarity working with nintedanib in rheumatology, and I had to go back and ask myself the question, why did the ACR bulk about, in this in the recommendations, why is it recommended conditionally? Why are they dragging their heels?
Mhm.
And so the debate really centers around the cost and it centers around potential adverse effects, from what I could understand. And, maybe you'll have some thoughts about that, Alana. But in the short term, we're going to continue on some low dose prednisone to quiet down that inflammation. In this particular case, the patient was switched to abatacept for rheumatoid arthritis control, and methotrexate was stopped, which is interesting because I think we're still uncomfortable with methotrexate, and the questions are, pneumonitis. Are we still worried about some exacerbation of ILD? But um, so there is some discomfort with that, and this does not correlate necessarily with ACR guidelines either to switch to abatacept for rheumatoid arthritis control. Um, but so why abatacept? The I went and I looked into that, and there's definitely a lower mortality signal with abatacept. We like it, we're comfortable with it because it's generally a safer medication. It's got a lower mortality signal, for instance, than rituximab, which is recommended. And it's got a very favorable pulmonary safety profile. And ILD, it has a pretty good record. ILD will not necessarily worsen for these patients on abatacept. So, there's, that's a quick, a few thoughts about that, a quick summary. But ongoing monitoring, we're going to work with pulmonology to get this patient PFTs every 3 to 6 months, repeat that HRCT at 12 months, and continue to monitor for any disease progression. So, do you have any thoughts about that, Alana, before we move on to the next slide? Did I
I think
cover everything okay?
Yeah, I mean, I think you did. I think the idea, at the beginning of all this, I say at the beginning of all this, it's really not that long ago, right? And we're kind of still um learning about this, right? We're learning about, interstitial lung disease and how the immune system is attacking not just the immune system but also the lungs, right? And how that happens. So I think, that initial when your initial question was, well, why suppress the immune system first rather than starting an antifibrotic? I think what we know within the last 3 years is that we really are trying to target that immune system and really stop that progression of that disease if it's particularly triggered by an immune response. I think the tides are changing a bit, and we're starting to learn more about when someone has interstitial lung disease, what that fibrotic pattern looks like, and how it doesn't go away, and that more therapies are starting to be studied and added where they're going to be stopping. If they see the fibrosis, they will start a therapy like an antifibrotic therapy. Oh, that'll also potentially target the anti-inflammatory, which is part of the
Yeah.
immune suppression, right? And there's even studies we learned about today that potentially could be targeting risk, right? So if somebody even just has this patient but no fibrosis, should we be proactively treating the fibrosis that's not there yet, right? And so we kind of this is all coming to fruition, right, in the next, years to come, but I think you'll see the tides will change in this space the more and more we learn about, what does that honeycombing or UIP pattern really mean long term, and can we prevent it from occurring? And so,
Right.
yeah, just wanted to add.
Yeah. Yeah. Can we, can we yeah, exactly. What can we do to prevent it from occurring? I like how you, end with that. And speaking of ending, just kind of the summary and the teaching points. So we do know that high-risk RA patients need proactive ILD screening. Does that mean that we screen everybody? Everybody gets a HRCT? No.
Oh,
But we're,
be glowing.
yeah. So now we have some things to look for. We're looking both for clinical presentation and we're looking for those high-risk factors that we discussed today. Certainly, the DLCO, the PFTs play critical roles in early identification. Watch for that UIP pattern. And we talked, last time we met as a group, we talked about the association between the UIP pattern in particular and RA. Antifibrotics can slow the decline. Um, we choose certain biologics as well to prevent worsening of ILD, whether it's abatacept, Rituxan, and then uh, or tocilizumab, for instance, and cross-specialty care with shared decision making. Of course, working together between rheumatology and pulmonology is essential. So we got to take a team approach to this.
Yeah. Thanks, Mary. And I'm hoping you'll help me with this next case because this patient it's getting harder to breathe. So this patient is going to be a progressive ILD with systemic sclerosis. And so this snapshot, this is a DA who is a 56-year-old Caucasian woman who comes in with worsening dyspnea over 6 months with a dry cough and has a history of known diffuse cutaneous systemic sclerosis for 2 years. And we can go to the next slide. And so some of her clinical features, and this is where I would call Mary up and say, could you see her, or can I just pick your brain at, a sidebar consult? So, she's got skin thickening proximal to the elbows. She's got Raynaud's and GERD. And Mary says, order a SCL panel and other things that I would order and then probably send her over to Mary. But what is that, Mary, for you? What does that positive SCL 70 mean for you?
Yeah. So when we're when we're diagnosing patients with scleroderma, we look for different antibodies, whether, and some of those can be anti-centromere antibodies, RNA-3 polymerase antibodies. In this particular case, positive SEL70 associated with diffuse scleroderma, and in particular, it's associated with an especially high risk of developing ILD. Um, 50 t so in all scleroderma patients, okay, whatever antibody they have, about 50 to 65% of all scleroderma patients are going to develop ILD on high-res CT. With positive SEL70 patients, that risk is increased 3.1-fold. So there is this amplified risk not only with that antibody, but, having that diffuse cutaneous involvement that we actually see on clinical exam. And so I would, again, if I see a patient, with this risk, I wanna get her into pulmonology, I wanna get her into CU, and again, Alana, if you could just speak to the baseline screening you would pursue, in this patient.
Yeah, sure. So, I mean, initially I would do the markers like you're saying, looking to see if does she have anything that I can point to. This one in particular does, but looking for that other markers like I'd want to know her, a PFT, right? Potentially a 6-minute walk test just to see if she's oxygenating well when she's moving around, and then a high resolution CT because, like you said, these individuals are very high risk with high mortality risk as well for end organ damage and particularly damage with ILD. So as well as renal failure, GI, and other things. But in particular, I'm really looking to see she's very high risk for the development of ILD.
Yeah.
Okay, so we can go on to the next. And okay. And for this one, so this lady, worsening dyspnea over 6 months. And, that often I say this is like the tricks of the trade, right? Like it's really difficult. Patients will say, I'm more short of breath. And you really have to get that good history about dyspnea because often what happens with patients is as they become more and more short of breath, they just start doing less. And so they even themselves may not notice, oh, I'm not walking my dog every day anymore a mile like I used to, or I've decided I'm no longer going to be going to the grocery store, 2 or 3 times a week. It's really hard for me. I'm going to go once a week, or I'll have it, delivered, right? And so, the body kind of compensates in the brain, right? It says, "Oh, I'm just getting older or whatever," right? And so really paying attention to that dyspnea. Are they having more dyspnea? Are they able to climb the stairs like they used to? Are they modifying their walking route, right? Like in the city, we would say, "Do you notice that you know where every elevator is or every steep hill
Yes.
is?" Right? So like, did you walk up 68th Street or did you go down 71st Street? And we want to know that because there's a hill on 68th and there's not one on 71st, right? And so, that kind of stuff. Like if you know that stuff and you're tuned into that likely is a sign that you're dyspneic and you're accommodating for that dyspnea. So asking about dyspnea is very challenging and really eliciting how the patient truly feels. And so, just putting that out there that it's not such an easy question to answer. Desaturating with exertion is really important. Having them do a 6-minute walk. The walking 6-minute walk test really is supposed to be on level ground. But for some patients, they really only desaturate when climbing stairs. And so I would have a stairs, off to in our building that we would be able to test them on stairs as well. Just to see. I mean, obviously you're pushing them with exertion with stairs, but if they live in, a fifth floor walk up, like is a common thing in New York City. If it's less 5 floors or less, they're not required to have an elevator in New York City. And so just knowing that is really important. For your PFTs there, you see the FVC is reduced 71%. It's not super low, right? But it suggests a restrictive pattern. And then you have there that DLCO that's 52%. You would say to yourself, wow, that's pretty significant, right? So should be 80 to 100, or more. So having 52% of the diffusion of the oxygen capacity there is quite low. And then it's downtrending from baseline. So what's important here to note is downtrending from what? So like, was it 82 when it went to 52? That's very dramatic, right? Did the person have COVID or something going on there? Or, and what is the time period? That's the other thing that's important here. So, you're looking at 10% change is considered significant. However, 5% can be significant as well if you have other manifestations, whether if it's radiological, right? So you're having manifestations of fibrosis in your CAT scans or in your symptoms, right? And so knowing what the baseline was is really important because you need to know, is that a 2% change? Is that a 5% change? Or is that a 10% change? And is that change over 2 years or 2 months? Right? Because that also makes a huge difference on the mortality and what you're going to do next. Right? So if I said it's, a 2% change over 2 years, you're going to say, okay, right? Like, okay, that's okay. It's reasonable. Right? But if I said, a 10% change over 2 months, then your mind is thinking, okay, does this person need to go on a transplant list, right? And so two very different things, ways of thinking, just from that data point. And then the high resolution CT for this lady had early honeycombing with the UIP pattern. The typical UIP pattern has basal and subpleural reticulations with traction bronchiectasis and honeycombing without features inconsistent with UIP. And so it's really important to have that multidisciplinary discussion for atypical or indeterminate findings. But for this particular patient, UIP pattern is pretty consistent with fibrosis. So what are the next steps in management? Mary, would you put them on an immune suppression drug? What are your thoughts about starting
Yeah.
on some type of suppression?
That's a great question, and, first of all, I would add no steroids for these patients, and particularly our RNA-3 polymerase patients, where we're really worried about, scleroderma renal crisis, but we're going to avoid the steroids. Um, you know, this is interesting because this is where we really collaborate with pulmonology as rheumatologists. I think more and more you were more comfortable, for instance, with mycophenolate, starting something like that off. But at the same time, that what you bring up is about watching progression of disease. And when do we start them up? Should we feel comfortable at this point just starting them on mycophenolate? But then at what point do we need to escalate therapy? So you're bringing up that concern as well. And that's something that I would want to coordinate, take a team approach with you, in making that decision. The other thing that I love that you do is that when you're talking about your patient, you're listening to her story. Like you're listening to that story of dyspnea, of exertion, and you're just reminding me how important that is to ask those questions, not only here, but on our on our rheumatoid arthritis patient who, you're looking at his face. You're looking so we're really listening to these patients and that's not really a diagnostic criteria, but hearing their story is so critical. Um, I guess for me, no steroids would be one thing, and then probably like a mycophenolate, but I would tend, if I didn't know, to go to those ACR, those 2023 recommendations, those CREST recommendations, be familiar with the first line recommendations and work with pulmonology to go from there.
Yeah, yeah, I agree. I would defer to you about, what would we immune suppress them with. We were very commonly using mycophenolate in these patients. And there's really an argument here for starting them on an antifibrotic with that UIP pattern now. And seeing if they tolerate it. And even though it's not part of this presentation this evening, we do have a new therapy on the market near neramdomalas, which is both PDE4 inhibitor. So you have that immune suppression or anti-inflammatory piece there, and then it has the antifibrotic drug there. It's currently FDA approved for IPF, which is not what this patient has. However, the trial data is supportive that it will be approved for progressive pulmonary fibrosis, which is um, likely what this patient is having. So, in the future, I think we're not there yet, but hopefully that will be FDA approved any day now, and that would potentially be an option for this patient once it's approved.
Yeah, and we had talked about nerandomilast too the last time we met, both potential for ILD as well as fibrosis, and, from a rheumatology standpoint, that's pretty exciting, so it'll be interesting to see, what drugs like this are coming up the pipeline to help us address both the ILD as well as that fibrosis concern.
Right. So for this patient, they started her on mycophenolate, referred her to transplant clinic for consideration. She was 56 years old, so that would be a good age for transplant if she meets the criteria. And then, of course, review vaccine needs and potentially introduce palliative care. For this patient. What role do non-pharmacological interventions play here? Just thinking about, and I'm just thinking about, relaxation techniques and, how to do pursed lip breathing and how to help her, combat some of that dyspnea. I really like to do non-aerobic exercises with these patients, having them, seated in a chair and using kind of cans to lift weights to really strengthen that inter oh gosh, what do we call those? The muscles between the ribs. So your intercostals. Because when you start to lose weight from not having enough air to breathe, right? If when you can't breathe, you don't eat well because you're more focused on breathing. And what ends up happening is you start to wear away your muscles, right? You start to have muscle wasting. So really having some of that exercise that builds up those intercostals to help with your breathing support is really helpful, especially for end of life patients and things like that. So, just looking to see what you would do with her, refer her to a transplant clinic would be high on the list, particularly with her age, perhaps starting her on an antifibrotic. And so, yeah. And how do you monitor and adjust therapy? I guess I could ask Mary some of that as well
Well,
with
for
mycophenolate.
Yeah, I mean, for ILD, we're we have to think about all different organ systems when we're talking about diffuse scleroderma. So we're thinking cardiovascular, we're thinking renal, we're thinking skin, we're watching for any, digital ulcers, and so we have to. There's no drug for systemic sclerosis. There's no particular treatment just for that. So we really have to treat this on an organ system by system basis. And we're often coordinating with several, different specialists and trying to optimize the quality of life for these patients. Um, for instance, with joint pain, or early joint pain, maybe we're using hydroxychloroquine, maybe we're not, or there's there's a number of different concerns that we have. But I think for us, really, ILD is very serious. We also have to think about pulmonary arterial hypertension in these patients, and be getting them to making sure they're following with cardiology as well. So it's pretty complicated, and I could not do it alone. So yeah, it's definitely a coordinated approach, which is, when we think about these cases in general, it just underscores to me how important it is to take a cross-disciplinary approach, in these instances and in other autoimmune diseases that we treat. And we talked about this a little bit at our last meeting, diseases like mixed connective tissue disease, myositis, where we're working with other specialists. We're working with neurology, neuromuscular medicine sometimes, again with pulmonology. um, cardiovascular, dermatology. So it's a very much a coordinated approach.
Yeah. Yeah. Good point. So, just some summary and teaching points, recognizing high risk ILD and diffuse systemic sclerosis. I think we did a good job of showcasing that here. Importance of early recognition of progressive fibrosis and ILD, making sure you're, really talking to the patients about their symptoms, getting the appropriate testing and follow up. Initiating immune modulator therapy, in this case, mycophenolate, but also discussing the timing of antifibrotic therapy, right? So when is it time to start an antifibrotic if you're having, fibrotic patterns in their radiology findings or, symptomatology, right? And looking at the change from baseline is really important. And then timing of referral for transplant is also quite important. The earlier the better. We always say almost once we initially have the diagnosis that the person has, a disease that may potentially end up where they need a new lung. We should start the conversation early and often to see if that's something the patient even wants to consider, right? Some patients you talk about things like that and they say absolutely not. I don't want to consider it. And so then you say, okay, we're going to maximize, medical therapy, right? And whatever that is. And then, or no, I don't want medical therapy. This is what I want, right? So it's really an individual decision with the patient and really talking them through this. It's complex, but I think once you have that diagnosis and knowing what we know about this disease and how rapidly it can progress and what the mortality looks like, I think giving the patients all that information is really, really helpful so that they can make an informed decision. Um, and then you'll really know, what to recommend based on what they're saying that they want. So
Yeah, and I just you're reminding me of the importance of really getting these patients seen promptly because their risk of developing ILD is highest within that first 5 years right after diagnosis, and so we've really gotta get them, taking to you guys, take an aggressive approach, and be sure the patient is aware of the seriousness in that, when we're talking about deciding on medications, it's critical that, they understand the importance of getting on therapy as opposed to delaying therapy.
right, right, exactly. So final thoughts and discussions, and I guess you and I can both take this. So what are your key takeaways across both cases? I would say how important it is to have colleagues in other spaces, right? Thank God for Mary, that I can call her and message her and say, "Hey, look at this. What do you think? Here are these labs. What am I supposed to do with this? And can you see this person?" Right? I think having that interdisciplinary, shared conversation is really important. And access to specialists in those fields is really, really important.
Yeah, and for me, I mean, just working through all these cases and really brushing up on ILD, it's just for me, I think my awareness of ILD and the prevalence of it is is heightened, and also my confidence in knowing what to do when I meet these patients. What's a high risk patient? How do I? What signs and symptoms am I looking for? What's the diagnostic workup? I think understanding the language of ILD, UIP, NSIP, what's the difference? We didn't really get into NSIP so much, but or organizing pneumonia. I think just the awareness and the confidence and the ability to recognize this and feel more comfortable with it has been a great experience for me.
Okay, great. Yeah, I mean, I think that answers the second one with, shaping your ILD suspicion and management.
Yeah.
Certainly your awareness is heightened. Education is great for, heightened awareness. And what part of the diagnostic or treatment timeline do you feel most confident in or least confident in? I think if you can get them into, I think similar to what you were saying is that, the typical time to diagnosis for these folks is, 2 years. And so really getting them into somebody who can understand their disease, understand what the root cause of it is, and getting them to that specialist or those centers that can get them the treatment and get them on a list if needed is really important if that's what the patient wants. So,
Mhm. And, in fairness, what part of the diagnostic or treatment timeline do you feel most confident in versus least confident in?
mhm.
I would say I'm probably more comfortable with the upfront part of it, the diagnosis and maybe initiating treatment. But I think there's still a lot for us to learn as far as monitoring disease progression and knowing, when do we go to that next step? What are the therapies out there, especially as disease may become more advanced? And also, I think um, we're always going to be looking to become more comfortable with the different biologics that we use in rheumatology. I think there's still a lot of when we're talking about methotrexate versus abatacept versus Rituxan, there is s there's a lot of discussion to be had out there and studies to be done about the relevant, efficacy of these medications. And also, I need to become more confident in the therapies up, in the pipeline and what's ahead. And I'm excited about that, but there's definitely a lot of learning to be done there.
Well, thank you so much for joining us. I'm part of APAP, which is the Association of Pulmonary Advanced Practice Providers. I serve on the board there, and um, Mary is with RAP. And so, so happy to be with you guys and being able to give you this, education.
Yeah, it was really enjoyable. And I would encourage, if you're in rheumatology, I would encourage you to join RAP. If you're in pulmonology, join APAP, and we cross pollinate too. We can join each other's, can't we? I think.
Yes, we can.
But all right, this was a lot of fun. I learned so much working with you, Alana, and certainly, if any of you are out there have any questions, want to connect. Please feel free. I'm the New England RAP representative. If you're in New England, please join RAP, um, and hopefully we get a chance to connect in the future and
Yeah.
keep the conversation going.